All right. So we're going to talk about esophageal perforation. So Andra, are you there?
Yes, I'm here. Can you
Okay.
hear me?
Yes.
All right.
So let's go through some quick cases. So you receive a call from the endoscopy suite. A GI doctor is asking for your help evaluating a patient over there. They performed an EGD as part of the workup for a presumed GI bleeding 6 hours ago. But the patient is in the recovery area and is now complaining of neck pain and some adenophagia. So is there anything else that you want to ask them while you're on the phone with them?
Yeah, so I would ask about sort of, first of all, a set of vitals. Is the patient stable, unstable?
They're not at the bedside. They have to go and do another endoscopy. So they would really appreciate your help.
All right. In that case, I would just hang up and go down and see the patient myself.
Very
Okay.
realistic.
What's that?
So it's a very realistic scenario.
Yeah. Do you want to know what they found in the EGD? Would that make a difference?
Yeah, why not?
Okay. So just some mild esophagitis in the distal esophagus, but otherwise the esophagus was normal, the stomach was normal, the duodenum was normal. They couldn't really find a source for that bleeding that they were trying to find.
Okay.
They say that they didn't really have any difficulty doing the EGD. They struggled a little bit at the beginning putting the scope in, but nothing out of the ordinary.
Okay.
They haven't done any studies.
And they're able to visualize the whole esophagus and no distal strictures or
Yep.
malignancy or, okay.
Yeah, just what I told you. Yep. So you finish the call, you go to recovery area. So while you're walking over there, what's your concern? What's your differential diagnosis?
Yeah, so I think obviously the first thing that comes to mind is I think the worst thing you have to rule out is an esophageal perforation, especially with the recent history of instrumentation and then new onset of chest and neck pain. And then I think you have to also rule out other cardiac causes of chest pain and not get caught in the trap of just thinking it's esophageal. So rule out cardiac and then focus in on a possible esophageal perforation.
Perfect. So you're walking over there and you remember that there are three main points of relative narrowing in the esophagus where most iatrogenic perforations can occur. Can you remember them?
Yeah, so the first one, which is most common to occur with instrumentation, is right around the cricopharyngeus muscle. The second one would be the narrowing around the arch of the aorta and left main stem bronchus, and then the third would be the diaphragmatic hiatus.
Perfect. So you get down there. How do you assess this patient? Here are your vital signs.
Okay. So the patient has a low-grade temperature. They're not tachycardic. Blood pressure is a little bit soft, and they're statting relatively well on 1 liter. So, you know, these patients can obviously be very sick, and they can get sick quickly. But I think for now, I have a little bit of time, so I'm going to start in with a focused, very short history and physical. So. I kind of already have a sense of the onset and duration of symptoms. So it's been about 6 hours after the EGD. And then I would ask about any history of vomiting or hematemesis.
No, he just had the procedure and now he's complaining of neck pain in the recovery area. So
Okay.
That's pretty much the history. What are you looking for in the physical exam specifically?
Yeah, so specifically, I would look for any evidence of sub-Q emphysema in the neck and chest area. I would listen to lung sounds. You may be able to pick up some diminished lung sounds on the side with a big effusion if that were the case, and then a cardiac exam, and then abdominal pain to rule out any pain or peritonitis.
Okay, so let's assume that at that point the physical exam is otherwise normal. There's nothing significant. So is there any test that you can obtain down there in the recovery area that can help you, or what would be your next step?
And then just to round out, any other notable past medical history, meds, allergies?
No,
Okay.
nothing.
All right. So I mean, right now we're in the endoscopy suite, so we're probably a little bit limited. I might talk to them about transferring this patient to either the ED or an ICU level of care, but I'd want to start doing some initial workup. So, you know, maybe down there we could get an upright chest X-ray and an EKG, But then I'd also want a full set of labs, complete metabolic panel, CBC, coags, type and screen, probably a set of blood cultures. And then I would start making arrangements for a gastrograph and swallow.
Okay. So this is the X-ray that you obtained down there. What do you see?
All right, so this looks pretty reassuring. The lung fields look clear. There's no large pleural effusion. The mediastinum doesn't look widened. I don't see any significant pneumomediastinum. There's no free air under the diaphragm.
Great, excellent. You touched on all the important points. So let's say, assume that you have this. Yep.
What's your confidence that a contrast study would show you the problem?
So I think if there's a large leak, that it'll be pretty good. But I know that with small perforations, it might not be great. In which case, I would sort of tell them before they went down that if they weren't able to see anything with gastrographin, they could repeat that with a thin barium swallow.
And if you didn't see a perforation, would that change your management?
Well, in that case, I would probably, I would consider more of a conservative non-operative management strategy. I'd probably keep them NPO on antibiotics and a PPI for a couple of days as opposed to talking about any intervention.
But you might not see a perforation that exists on a barium swallow.
Correct.
It sounds to me like Andrea is already appropriately convinced that the patient has a perforation regardless of what the studies show, which I think is the takeaway point. But the gastrograph and swallow might show if it's a perforation that requires intervention.
But if you don't see a perforation, would you not, what guides you towards an intervention?
So I think based on the clinical stability of the patient. So if they remain hemodynamically normal, they have no systemic signs, their imaging all looks okay, then that would all guide me away towards any sort of intervention.
Yeah, the question is whether you really need the barium swallow.
In this case, I would get it just because I think that we have time, and I have a pretty high suspicion for a possible perforation that might require some sort of intervention.
I think if you see free extravasation on the barium swallow, that completely changes it, don't you guys all think?
Agreed.
Remember that there's a more sensitive study that we've developed, CT esophagram, that can give you more detail.
Correct.
As well.
Right, so Andrea, to that point, so this is the swallow that you obtained. Do you see anything, and what do you do next?
Yeah, so this looks like a contained perforation in the cervical esophagus.
So the radiologist calls you and says, it looks like a normal esophagram. What's the history here? So they don't really see anything. It looks pretty normal. So to the point that Dr. Geiser was making, sometimes you cannot see them or there's no active extravasation. So with that history, with that clinical scenario, and with this study, what are you going to do with this patient?
Okay. So this little wisp of contrast they're saying is normal here.
This is a normal swallow, yeah.
Yeah, okay. So, I think sort of the classic thing that they talk about is if you're negative on a gastrograph and swallow, you can repeat it with thin barium, which is a little more sensitive, or you have the CT esophagram. So if this patient was continuing to complain of pain, if there were any changes, the next step you could consider was that CT imaging.
Perfect, agree. Let's say you decide just to admit the patient. So what are your instructions to the floor team or whatever ICU team, wherever you're gonna admit this patient? Exactly what are you gonna order and what are you gonna instruct them to do?
Mm-hmm. So if I had a high level of suspicion, I might admit this patient to the ICU or a step down level of care just for a closer level of care. I'd make sure that they have appropriate access, at least to large bore IVs. If there was any concern that they were hemodynamically unstable in A-line, I would then start them on, or I'd make them NPO, start an IV PPI, broad spectrum antibiotics, if we're thinking this is a small perforation. And that should include gram-negative, gram-positive, and fungal coverage. So something like vancomycin fluconazole, I think, is appropriate, at least to start.
Okay. Perfect.
I think to Mike's point, I do think, and I don't know how the others practice, but I tend to get a CT esophagram, and I order it as, esophageal protocol, because otherwise it doesn't get done correctly, at least in my history, that they need to know that's what they're looking for, because then you can tell if that wisp is really not. You'd manage them the same, so I get that point, but at least on board exams or whatever, if you add that point, they realize that you know about it and thinking about it.
Okay. And that's your first test of choice as opposed to a swallow?
It often depends on what you can get.
Okay.
At what time, right?
That's usually what I end up getting.
Yeah, I do, because that's what I can get easier than I can get a swallow.
Right. They don't want to come in at night for a barium swallow. You could make an argument that barium, not gastrographin, but a barium swallow is more sensitive to certain things. But if you're splitting hairs that much, it's probably an injury that doesn't need immediate intervention.
So is it fair to say that if you're leaning towards a non-operative management based on a barium swallow, you get a CT scan just to make sure that there are no big undrained collections or anything else that it's going to push you to do an intervention?
Right, and I think the CT esophagram also gives you extent of pneumomediastinum effusions, so more information that you might want to, if you see more extensive pneumomediastinum, maybe you want to scope them sooner rather than later.
Okay.
When you order a barium swallow for an esophageal perforation, they'll actually do a water-soluble contrast swallow. Then they'll switch to thin barium if the contrast is negative, because thin barium is a little more sensitive than water-soluble contrast. But once you've given them barium, it's going to wreck your CAT scan if you just decide to get a regular CAT scan to look for a fluid collection or an abscess, because you'll have all the artifact of barium.
In this case, the timing matters a little bit too, because it's only 6 hours. It's just EGD, so I don't think you're going to see a big neck abscess right now.
All these things make a lot of sense, but you could also manage by saying, well, I make the diagnosis on my examination and on what the signs are, and then I observe the patient unless the patient has fever, tachycardia, anything else. I will observe on antibiotics. And so the diagnosis leads to antibiotics, and the decision about intervention is made by the vital signs, by the development of tachycardia and fevers. And then you don't have any study, but you could still manage the patient appropriately. And in this kind of environment today, COVID-19, I would think twice about sending the patient for radiographic studies.
But I'd be hesitant to do that on your boards. I would not do that pathway on your board.
I said so, yeah.
They just, and it's absolutely fine. It's totally fine. I just don't want you to I want you to understand that. Don't say that on your boards.
Absolutely. All right, Andrea, so you admit the patient, you do all those things that you mentioned, and then the next day you see the patient again, no fevers, vitals are normal, the neck pain, the very mild crepitus that you felt are much better, white count is 11. What do you do now?
All right, so that's all reassuring. So as Dr. Geisler had mentioned, sort of the clinical symptoms might push you towards intervention. So in this case, I had a very high level of suspicion to start. So I would continue the course. I would treat conservatively with the same interventions that we had mentioned for about a week, and then repeat imaging just to make sure that there's been no progression, no development of an effusion or anything that needs to be addressed.
Andrea, I can tell you that this is a very realistic scenario, and you're going to get this call a lot for healthy people, EGD, upper esophageal perforation, and it's not tenable to keep them in the hospital for 7 days, NPO on IV antibiotics. So you do, even though I think it makes some sense, you end up being a lot less conservative than that in real life, because you can't keep a 30-year-old in the hospital for a week not eating anything. So at least I send these patients home the next day on a clear liquid diet and oral antibiotics.
Okay. And then do you bring them back within a week to see you in clinic with any follow-up, or you just send them out?
If they're doing clinically well, they don't ever need to see me again.
Okay.
I would usually do a convalescent EGD myself, just to make sure there wasn't any structural abnormality from the injury or that was actually underlying the injury. Because I figure the EGD they got from the gastroenterologist wasn't very good, or they wouldn't be seeing me to begin with.
When do you do that, Dr. Allen?
Oh, a month later.
A month later. Okay.
I must say, if I may, sending them out on day one, if you see a true microperforation, would not be the standard of care. I think it's a movement towards that, but the board answer would not be to send them home. And so
Correct.
most people would be saying antibiotics with some duration of NPO, be it 3 to 5 to 7 days. And I must say, if I'm going to do that sort of shortened management, I would re-image them before they go home with a CT esophagram.
Great,
I
thank
think
you.
it depends on how reliable the patient is too. If they're pretty reliable, I think Hugh's approach is fine. If they're not, I kind of keep them in-house. But I agree, 3 to 5 days of NPO or clear liquids. I think saliva and clear liquids are roughly equivalent. So I'd probably do 2 days of NPO and then let them have some clears.
Excellent. All right, Andrea, let's short answers. So let's just move along. So let's go back in the case. So the next morning when you admit the patient, he reports more neck pain, had low-grade fevers, heart rate is 100, white count is 14. What's your concern? What do you do now?
So at this point, you know, he's looking, you know, he looks like he's getting a little bit sicker. I might repeat just a chest x-ray at the bedside to see if I see any sub-Q air or development of any effusion. And then I would probably not jump to going to the operating room just with those vitals, but I would continue very close eye. And if he were to get sicker, then, you know, you could think about repeating the CT imaging versus starting to talk about maybe an intervention at this point.
Okay. Let's say that either an esophagram or a CT scan was repeated. Let's assume this is the study. What do you see there? There are 2 arrows pointing at it.
Yeah, so now this looks like a perforation with some extravasation of contrast.
So the radiologist calls and says, yeah, there's an extravasation. It looks contained. It went in and out when we were doing the fluoroscopy. That's what we see. So what do you do with that?
Right, so a contained, especially cervical perforation, a lot of times you can manage in the same way. So NPO, antibiotics, a PPI, and then just see how the patient does. And if their symptoms tend to resolve or they get better over the next couple of days, you can consider or continue the conservative treatment. But if there is progression, in this case, they're starting to look more unstable, their white counts going up, they're having fevers, then you could think about a neck exploration. But at this point, I probably wouldn't jump to that just yet.
Okay. The next day, the pain is increased, there's fevers, and the white count is higher.
Okay, so at this point, I would talk to the patient about surgical intervention. I would probably book them for an EGD and repair of a cervical perforation, cervical esophageal perforation.
So you book the case, and nursing and anesthesia calls you, and then they want to know exactly what you want them to do in terms of anesthesia, positioning, lines. What do you tell them?
Yeah, so I would say, you know, ensure that the patient has good access to at least 2 large bore IVs, an A-line, a Foley. I would start supine, and I would perform my own EGD just to see if I could localize the site of perforation. And in this case, he'd had the previous EGD, so we know that there's not distal structural malignancy, but that's always important to rule out, especially if it's the first time that you're scoping the patient. And then I would start with the EGD, and then after that, it was going to be a left neck exploration.
Okay, just very briefly describe what you do during the neck exploration.
Yeah, so I'm going to make an incision along the anterior border of the left sternocleidomastoid. divide the platysma, and then you're dissecting, sort of pulling medial to the sternocleidomastoid and the carotid sheath, and then lateral to the thyroid and the trachea. Incise the deep cervical fascia to identify the esophagus, and then obviously making sure to preserve the recurrent laryngeal nerves. And at this point, I would try to localize the site of the perforation, keeping in mind that a lot of times you're not going to be able to localize it. If I can't, then I would just wash it out and then widely drain it. And if I could localize it, then I would do a 2-layer closure, approximating the mucosa and submucosa with interrupted suture, and then running the muscle over that.
So exactly as you mentioned, you see some murky fluid, but you cannot localize it. So what do you do in that case?
Okay, so in that case, I would just wash it out and then place drains and close.
Okay, you place drains, finish the procedure. The patient does well in the early post-op period. Just in summary and briefly, what do you do post-op? When do you send him home? What's the routine?
So I would keep him NPO on antibiotics for at least a week, and then I would re-image. And if there's no evidence of ongoing extravasation, then I think you can start with a slow diet advancement at that point.
All right.
What if it was a really raggedy perforation, just the whole esophagus looks disgusting, and you know there's no good mucosal layer and no good muscle layer to close? You know, you wish you'd been in the operating room 3 days ago, but there's a big hole. You can see a big hole.
I don't know what you guys think. That I'd be curious your thoughts on this. Is that something where you would consider like rotating a strap muscle down just for a muscle buttress if you feel like you couldn't close the esophagus well, or would you just continue to drain that?
I mean, people describe repairing those over a T-tube with a muscle flap buttress. I've never done that or seen that. I don't know what my partners would do there.
I would agree with that. And then you want to think of feeding access for that patient too.
I would try a primary 2-layer closure, making sure you get all the mucosa and buttress it. The T-tube would have to be an extreme situation to do a T-tube closure, but that is an option. And it's not just it's a T-tube with the muscle kind of around where the T-tube comes out of the esophagus with a bunch of other chest tubes near it, so that there will be some leaking around there, and you want to make sure that area is drained and it all sticks down. And then you basically pull the T-tube after they formed a track, and you have a controlled esophagocutaneous fistula that collapses on itself. That's pretty extreme management.
Andrea,
Doug's done that a couple of times.
What we're discussing here is really a pharyngeal perforation. Now, what's different about, say, luminal pressures in the pharynx as opposed to the esophagus?
Well, you have an area of high pressure near right around the cricopharyngeus muscle. Is that what you're asking? Yeah.
So that knowledge, does that lead you to do anything else for this perforation, whether you find it or you don't find it? Would you consider a myotomy?
Well, I think that if I could localize it, I would consider a myotomy just to make sure that I can visualize the full extent of the perforation.
If you had concerns about healing somebody, for example, in somebody who's on steroids, you might add a myotomy to decrease the force of luminal pressure so that you don't have as much stress on the perforation.
Okay.
All right, good, Andrea. Thank you very much. Shana, are you there?
Yes, sir.
All right. So quick, short answers. All right, different scenario. The GI doctor tells you that they did a balloon dilation for achalasia. Everything went just fine, but the patient now has chest pain. What do you do?
So again, I'm suspicious for another perforation topic. So I would have them come to the emergency room. I'd want a full set of vitals. I want full physical exam top to bottom, full set of labs, at least a chest x-ray to start, and go from there.
So that's a chest x-ray. It's read as normal.
It does look relatively normal. Given the scenario, though, I think I would follow this up with some kind of contrast study, so a swallow study.
Okay, so you get a swallow study. This is the study, the official report, and when you talk to the radiologist, they say it's a contained perforation of the distal esophagus. Patient stable, afebrile, normal white count. What do you do?
I guess at this point I want to call back to the gastroenterologist to see about the success of the dilation. Do they think that it was successful, just to get a sense of what that?
Yeah, they put a 20 millimeter balloon and it went fine, like no issues. They didn't notice anything rare at that point.
Gotcha. All right. I would be tempted to repeat an EGD myself here, just to get the sense to see what it looks like on the inside, versus just watching the patient and managing, non-operatively for now on antibiotics. So.
Okay. Yeah. What about if you get this study? The patient is 6 hours after the procedure.
So right before, I disagree, because you have likely a distal obstruction.
Well, so that was the question of whether the
20 millimeters won't open up anything for achalasia.
There.
Right, they usually go to 40, and that's why the risk of perforation is higher than kind of what we deal with.
I think at a minimum you need an NG tube that sits just high to that area.
Okay. I agree with both. I think I was trying to sort of get at that with the asking the gastroenterologist, and I think in this situation I'd probably scope him myself as well.
Shana, you also want to look at the barium swallow before the procedure, because there are some patients with achalasia who have an esophageal diverticulum. It doesn't look like an epiphrenic diverticulum, but you want to make sure that it's not present.
Good point. Yeah. Shana, let's say that the swallow showed this. So what do you see?
Okay, I think you're trying to point at the fact that the contrast is now spreading into the pleural space there, or essentially it's not a controlled perforation. Is that fair, or am I missing something else?
Yes, there's contrast fully going into the left chest.
Gotcha. Even though the patient is still stable, given the underlying pathology and the fact that this is not controlled, I'd be tempted to operate on this. And my thought would be, going to the operating room, 2 large 4 IVs, an EGD to visualize the pathology. And then my operation would address both the perforation and the achalasia at the same time. So I would
explain what does it mean?
Yeah. So I would do a low thoracotomy.
Right, left.
This is at the G junction. So I would go left here.
Okay.
And so low to get down to everything. On the way in, I would mobilize some kind of muscle flap for coverage, intercostal probably. Mm-hmm. I would look for the perforation itself and address it in the standard fashion. So I would extend it, the muscle injury, so I could see the perforation well, with plans for a repair of the mucosal injury with absorbable suture and then permanent suture for the outside. And then for the achalasia itself, I would perform a halar myotomy, and that would involve sort of going to the opposite side of where the defect is, and making myotomy to get to that. I would cover my perforation with the muscle flap that I mobilized going in, put drains, and close. Okay.
Besides muscle, any other flaps that you can use?
But pericardium is an option, pleura is an option, omentum is an option. I think if you can get muscle early on, it's probably the best thing to do.
Yeah. I would say pleura is worthless unless it's chronic inflamed pleura. I wouldn't put pleura on anything, having had a bronchial stump that I once covered with pleura and was very disappointed.
Okay, sounds
I
good.
agree.
You can't beat a left thoracoabdominal incision for a GE junction pathology. It really lets you do anything that you could possibly need to do in that operation.
Yeah, and that's it. I think that pushes to this. So anything else you want to do, I think thinking about some kind of feeding access, having a thoracoabdominal would have been nice to give them a feeding tube or something. Thinking potentially if they need something in the future, I wouldn't love to get in the stomach, so a J tube might be my choice, but the G tube would be reasonable here as well.
Excellent. Good, Shana.
What would you do if this person were really, really old and sick and they couldn't possibly tolerate that operation? How do you keep them alive and squeak them by?
Interesting. I would go to the operating room. I would drain them maximally, give them feeding access, and get out of there, I guess.
And
What about a stent?
maybe put a covered stent of some sorts over the area as well.
So stents around achalasia, I guess, is I just don't know that I'd be able to get distal enough to
You
put
would.
a stent.
You jam a stent
actually would
through the
hold
G
your
junction
stent.
and cover the hole. Nice long stent.
So
Yeah.
it's sort of
The
beneficial.
problem is the diameter of the esophagus. The esophagus is very large and the stent is very small. So then you have pooling of fluid above the esophagogastric junction and not really an effacement and a pressure on the hole. And I would be concerned about that.
Fair.
All right, excellent. The point of that case was just to always think that you need to address distal obstructions, masses, other pathology when you're dealing with this perforation. All right, Shanna, quickly, last case. So you get a call from the ED. A guy just presented who was out last night drank too much, ended up vomiting. He's presented with some abdominal pain. No fever, but mild tachycardia. He presented about an hour ago.
So kind of like the last case, I'm concerned about a controlled perforation here. This sounds like a classic Boerhaave presentation, but I would go along the same pathway of sort of full vitals, full labs, full physical exam, and the chest X-ray and a swallow study.
This is the chest X-ray.
So here I see a bit of a left-sided pleural effusion. I can't see in detail if there's any air in the mediastinum, but this would prompt me to certainly get a swallow study, a contrast study, to see what's that's associated with.
So your options are contrast study or, okay. So let's assume that the patient got really sick when he got to the ED, was transferred to the MICU, got intubated, sedated. You get called after the fact, and after he's stabilized with the concern for esophageal perforation. What are your options to work this up?
So I think that this patient cannot tolerate obviously can't participate in the swallow study. I think a CT is sometimes a good option. Ideally, they'd be able to get some kind of contrast, enterally, but that might be tough here as well. But I think a CT would give good information about, inflammation around the esophagus, fluid in the pleural spaces. So, if they're stable enough for a CAT scan of chest, abdomen, pelvis, I would get that.
Besides a CT, what other option do you have?
That's really the main thing. I guess you could scope them at the bedside there too, but I'd want some kind of additional imaging first.
Yeah, it's an option to do a scope as well, I would say. Okay, so back to the original case, you get a CT swallow, and then this is what you see.
Yeah, so lots of pneumomediastinum. Thankfully, we're able to get contrast, and there's contrast extravasation. There's bilateral pleural effusions. This is a bad perforation. This patient is young, if I'm remembering correctly, and I think I would, as long as they're not on, max dose pressors, I would lean towards offering them an operation as well. Let's say you decided to put a stent to treat this patient. So what are some factors that would indicate that a stent is not a good option? Definitely the size of the perforation and the general sickness of the patient. So somebody in pressors, I guess that could go either way, but I would lean towards giving them an operation. Someone with additional pathology, so a person with an esophageal cancer, I guess the achalasia one is debatable. Generally, people who have pathology that needs to be addressed, stents are not always great options for.
What about location?
So that's right. So location, sort of higher at the top of the bottom. So high up close to the cricopharyngeus or the upper esophageal sphincter is not great. And then low down by the G junction is also not fantastic.
Hey, Shauna, I would just offer a different opinion. I mean, and I'd be interesting to see what the experts think. But if this patient was really unstable on a bunch of pressors, you don't think putting a stent to temporize and maybe draining the left pleural space and then taking the patient to the unit and resuscitating prior to any sort of operative intervention would be the right thing?
It's the way to go. He's young. I'd want to address it quickly, but I'd want to see what other people think. Yeah.
I mean, in my mind, like hemodynamic instability is more of an operation for damage control or more of an indication for quick in, quick out than definitive operation. Is that
what I would agree with Jordan for that, at least on the boards when they tell you he's unstable on pressors. I think that would be the chest tube, stent, temporized, fix at a later date.
Agree. And if you feel like it's not stentable and your patient is septic and you have, you know, really large perforation with necrosis and all of that, what is another option?
Yeah, diversion.
So you could divert them, yeah. Yeah, just drain and divert and come back later. Yeah.
So on your boards, they're going to want you to be more specific on just, besides just saying diversion.
Oh, so I would do a cervical diversion, divert the esophagus and the neck, and drain the left pleural space widely.
Yeah.
All right, Shauna, so how do you place an esophageal stent? Just describe it.
Yeah, of course. A few different ways to do it. What I'm comfortable with is doing this with fluoroscopy. So I would start with an EGD. I would use external pins to mark the sort of the boundaries of the perforation based on my EGD. I would then pass a wire down past the perforation into the stomach, pass my stent over the wire, and deploy it, making sure that it's again sort of appropriately straddling the area of perforation. And then I not everybody does this, but I would do a post EGD to look at my stent in valve position.
What do you do about the left pleural effusion?
So if all I do is an EGD and a stent, then they would get chest tubes to drain the infusion.
Any other options?
Besides getting it out,
Okay.
I guess the other option is a thoracotomy and a washout without necessarily addressing the
or just the
perforation.
bats, yeah.
Or bats, yeah.
Just getting back to the diversion, a couple of technical points. One, save as much esophagus as you can. I'll try to fish the esophagus out from the neck way down into the chest and pull it out and then tunnel it over the clavicle and put the stoma bag on the over the pectoral region. There's plenty of submucosal blood supply, and that esophagus will survive even if it's kind of stripped laterally for a good long distance. And then on the other end, if you've stapled over the stomach or the distal esophagus or something, put a couple of 0 prolines on it and cut them long. It'll really help when you go back in because you'll find it in 2 seconds. And otherwise,
Jim, what you're describing here is a situation where you're really giving up on the rest of the esophagus. So there's some pathology in that esophagus that you say is not going to be reconstructible. I wonder whether anyone would consider a diversion in an esophagus that is otherwise structurally sound and where you plan to reconstruct at a later time. I would find
talking about bringing out a side, a side pharyngostomy or something.
But that doesn't really do good salivary diversion, right?
No. It's an extreme circumstance, I think, that you would do that. But yeah, you're basically saying, I'm going to come back and pull the stomach up later, tubularize the stomach and pull it up and do some sort of anastomosis that's perhaps extra anatomic.
The 2 times that I've had to do this, I've learned from Dr. Morse to just leave the esophagus in situ, drain it with a pharyngostomy tube, and then your reconstruction options are much more varied when you come back. And I've been very grateful the 2 times that I've come back that the esophagus was still in the distal posterior mediastinum, and we had much more reconstructive options.
Yeah. So Shauna, so after you place the stent post-op, what do you do specifically about the stent?
As far as how long you leave it in there?
So
I guess.
Do you need to check the stent every so often, or you put it in the OR and then it's good? Or
I would get a baseline X-ray and then keep an eye on it with serial X-rays over time.
Do you want to get a swallow and confirm that you have a good seal?
That would be nice. Yes, I would do that shortly after the operation.
When do you do that?
Post-op day 2, as long as patient is stable.
Okay. So what are potential complications from stents?
Yeah, so we discuss migration as a possibility, and that depends on the location and the patient's anatomy. Stents can also erode and potentially further worsen the perforation. Those are 2 of the big ones.
Okay. And then how do you manage it in the long term? When do you have to take it out? Or
I think they can sit up there up to 6 weeks. So I would do at least that, and then at the 6-week mark, scope them, and you may need to replace the stent if you take it out then, but that's what I have in my mind as the longer extent of how long you can have them in there.
Would everybody agree with that?
I personally do less time, about 3 to 4 weeks.
Okay.
Just so the longer it's in, you have more granulation tissue develop, more risk of migration. You just don't want to lose these patients because sometimes they migrate and the patients don't even know. And that can be a problem with erosion into the stomach. So I think it's better to keep a closer eye on these patients, in my opinion.
All right, Shanna, quickly to finish, we have a couple more minutes. So the stent migrated, you replaced it, it migrated again. It's 5 days, sepsis is not controlled. What do you need to do?
I think this is bringing us to that, the diversion and drainage pathway that we sort of just discussed.
Okay. When and what are your options to reconstruct this patient long-term?
So definitely wait at least 6 weeks, but probably closer to the 3-month mark. I doubt that a primary repair will be possible at the time. So an esophagectomy with the standard conduits would be an option. Stomach, colon, jejunum, things like that.
Well, if you did an
How would you do
esophagectomy,
it?
yeah.
What route
Pardon?
would you take?
Oh, well, yeah, right. So going, into the same space would be challenging. I guess is what you're getting at here. So I would pass the conduit. You can pass it in the answer. A sort of substernal location is an option. If the perforation is focused in the right chest, you can go in the left chest afterwards. You can do a thoracope abdominal to get to that and mobilize your conduit the way you want.
All right, I think it's almost 7:45. I had some review slides I'll share with the residents, but we just ran out of time. Thank you very much for participating. That was great.
Thank you.
Good job.
Thank you.
Thanks.
Yeah, well
Nice
done.
job,
Thank
Luis.
All right.